All for joining this first CME hosted by AKMG for this year. I'd like to first invite the president of AKMG, Dr. Sindhu Pillay, to give the welcome address.
Thank you, Dr. Raju. Good afternoon, good evening, everyone. I'm Sindhu Pillay, pediatrician based in California, and the current president of Association of Kerala Medical Graduates. Welcome you all to our very first session of CME, virtual CME series of AKMG. AKMG has been always proactive about its educational activities, and the CME program has been an integral part of our annual conventions for many years. We have our most efficient CME core committee team here, Dr. Ravi Raghavan, Dr. Shija Pularkart, Dr. Khalil Ashraf, under the great leadership of our CME chair, Dr. Raju Pillay. They have been working hard to put together the CME program, and we plan to have CME programs quarterly for the next 10 months and concluded by our grand live session of CME program at our annual convention. So our 45th annual convention is scheduled on August 29, 30th, and 31st at the Hilton Bayfront, San Diego. And we welcome you all to the convention. Registration is currently open. Early bird registration is going on. And we are planning to have the CME sessions until August, every 3 months. Our next CME session will be in January. Our topic and dates will be announced later. We also have a celebration, grand celebration of Kerala Piravi on November 5th, Sunday. We are planning to have some cultural entertainment programs along with unique art forms of Kerala, including a Kathakali presentation. So welcome you all. Please do not miss it. Join for that as well. Today, our topic for the virtual CME is the topic we have all been eagerly waiting for, role of AI in medicine. I would like to welcome our speakers, Dr. Rubin Pillay, Dr. Johnson Thomas, and Dr. Elakkat Gireesh. It is my great pleasure and honor and pride to introduce our CME chair, Dr. Raju Pillay. Dr. Raju Pillay has been familiar to all of us. He has been very active in organizing our CME activities for our AKMG California chapter. He's Director, Research Histology and Research Molecular Pathology, Core Laboratories, Associate Clinical Professor, Hematopathology and Molecular Pathology, Department of Pathology at City of Hope National Medical Center. He's an alumnus of Government Medical College, Elakkat. We have a lot of Elakkat alumni here, I can see. He did residency at University of Southern California, Los Angeles, fellowship at University of Pittsburgh Medical Center. He's a diplomat of American Board of Pathology. Raju has many leadership roles in administrative, academic, and research services, numerous publications, and is currently working on many grant projects also. It's my great honor to introduce Dr. Raju Pillay to introduce the speakers of today's presentation. Raju.
Thanks very much, Sindhu, for the introduction. Okay, so let's go to the next slide. I'd like to briefly overview the program today. So first of all, let me take a moment here to introduce our CME team, which has been working really hard to coordinate all the activities of this year's CME. Next slide, please. Can we go to presentation mode? Okay. So today's program, we have a panel of distinguished speakers Dr. Rubin Pillay will give the keynote address, and then it will be followed by two mini presentations from Dr. Thomas and Dr. Gireesh. After that, we will have a panel discussion with all our speakers, and we will have time for audience to ask questions and also, to have engaging discussions. So to introduce Dr. Rubin Pillay, Dr. Pillay is the Marnix Hirsing Professor of Biomedical Innovation and the Assistant Dean of the School of Medicine at University of Alabama in Birmingham. He is also Editor-in-Chief of Innovation and Entrepreneurship in Health and has a long track record of the application of artificial intelligence in medicine. He has written multiple books and published multiple papers. He is also Executive Director of the Hirsing Institute of Biomedical Innovation at UAB. And it is a delight for us to have him for giving the keynote for the session. So Dr. Rubin, the floor is yours.
Thank you. Thank you very much. Let me just pull up this. Yeah, well, thanks. I appreciate the invitation to present to the group. I think I should be an honorable member of this group, given my background. I think, genetically, I should qualify to join this group. So, well, I've titled today's presentation, AI in Healthcare, the Hope, the Hype, the Promise, the Peril, because I think it kind of summarizes where we are in terms of AI in healthcare and more specifically in medicine. And what I want to do is keep this non-technical, keep it very conceptual. I'll try and go through the slides pretty quickly. So if you have any questions specifically for me, I'll be happy to take them. What I want to do first is just cover, three basic principles that are very important if you are looking at technology trajectories and, more importantly, technology adoption in health and healthcare. Because as you'll know, it's easier said than done. Okay. But before I do that, if you want a good book to read that will give you insight into what the future will look like and how technology is going to shape it, The Coming Wave by Mustafa Suleyman is I would say, a must read. And in essence, this quotation summarizes what the book is all about. The risks of failure scarcely bear thinking about, but face them we must. The prize, though, is awesome. Nothing less than the secure long-term flourishing of our precious species. This is worth fighting for. And essentially, he's talking about technology and AI. And, I think for humanity's survival, not just for, better healthcare, but for humanity's survival, it's going to be imperative that we not just understand, but responsibly adopt and use artificial intelligence as well. Okay, so the three principles that you have to consider. One is actually has its background in technology. It's Moore's law and the law of exponentiality. That's really important because it describes the pathway that technologies take in terms of development. And as you can see, we tend to think linearly. That's human nature, but technology grows exponentially. And we often find it very difficult to try and, imagine the future simply because we are linear thinkers. A quick example to illustrate the difference. If I tell you to take 20 linear steps, you'll be 20 steps away. If I tell you to take 20 exponential steps, you'll be a few times around the Earth. So that's the comparison of something that's on an exponential pathway and a linear pathway. So you have to kind of understand that in the context of what I'm going to talk about in AI and pretty much for any other technology as well. Now, although this Moore's law just goes back, I would say, a few decades, if you scroll back to since the inception of humankind, the graph on the right-hand side shows you that human progress also follows somewhat of an exponential pathway. And, it's pretty interesting to see that. And you can see what is predicted. What sticks out is by 2050, human level artificial intelligence, meaning that we'll attain singularity around that time, depending who you listen to, around 2045, 2050. And the singularity is the point where artificial intelligence supersedes human intelligence. And, you can see where that happens on the curve. And when that happens, things become a bit unpredictable. It's very difficult for us to imagine what would happen. But we have to start thinking through something like that. 2075, humanity populating other parts of space. So just give you a sense of exponentiality. The second law is Amara's law. And essentially what this says, at the inception of technology, we tend to overestimate the potential in the short run, obviously, and then underestimate the impact in the long run. A common example of that is the smartphone. We really overestimated it as a phone. And we got really hyped up and excited when the smartphone was first launched, the iPhone, and thought it's going to be a great, communication tool. But we underestimated the long-term impact. The smartphone has pretty much changed how we live, how we socialize, how we communicate, how we access information. We never factored that in our excitement when the smartphone was first released. So that's a good case. AI is kind of in the overestimation phase at the moment, where we're getting very hyped up about its potential impact, not just in health and in medicine, but across other disciplines. But I think what we're doing is we're underestimating the long-term impact, that this is going to change humanity forever. So just bear that in mind. And the third one is what I call the elevator effect. And if you I know in India you still have elevator operators, but they're it's one of the professions, one of the only professions that automation has replaced in the USA. And, the automated elevator was invented 40 years before it became adopted. So the automated elevator, the ones that we use to now, was developed in 1900. It only was fully adopted in 1946 because people just didn't trust an automated elevator. They only trusted an elevator that had an operator in it. And, the major shift happened post 1946. And that was only when elevator operators went on strike. And people were forced to use the automated elevator. And, so the point there is, unless there's some major external shock, we don't tend to embrace technology, even if it makes sense and it's going to be valuable. So just bear those three things in mind, as we move on. So for the non-technical guys, I know we have two colleagues that are, understand the technological aspects of AI, but I think for the broader audience, we'll keep it conceptual. There are many definitions of AI, but the short, sweet, simplistic definition is it's essentially technology or techniques that enable computers to mimic human behavior. So, that's the short and the sweet definition. Currently, most tools are considered narrow AI, meaning that an AI tool does specifically something that it was designed to do. It does not have generalized intelligence. So, and that's an important thing to note. An AI algorithm to detect a lesion in a lung can only do that. It cannot do and accomplish any other task. So pretty much AI is very narrow and very task-focused at the moment. Our kind of closest we have to general intelligence is generative AI. So I'm assuming a lot of you are familiar with ChatGPT and all of the other large language models, but that's the closest we are to generalized intelligence. And that's pretty much, I think from a definitional point of view, what you need to know, okay? So a bit about the history, AI has been around for over 70 years, and it goes back to the early 1950s where the term was actually coined. And one of the enduring test to define artificial intelligence was actually developed then by a guy called Turing. And that's still the test today that computers have to pass to be classified as having true artificial intelligence. So if you hear about the Turing test, what it means is that if you ask a computer and a human questions, you should not be able to differentiate both of them from their answers, okay? That's the Turing test. And, to date, no computer has passed the Turing test. So definitionally, we don't have AI. What we have is machine learning. We are not yet, although we use the term, we're not yet in the AI kind of zone or space. So bear that in mind. Has a long history, remarkable achievements. Pretty much every game that humans play, AI is the champion now. It goes back to whether it's chess or Go or whatever game you can think of. AI is actually the champion. And bear in mind, I'm using the term AI loosely. So there've been a lot of remarkable achievements, and gradually what we're seeing is a significant improvement in the ability of computers or machines to actually mimic human behavior. So the history is very interesting, and it's a long history. It's a history of about 70 years, okay? Now, in medicine, it's no different, we also have a 50-year history of AI. And, there have been several publications, several products developed over the years with not much success. But, we have dabbled in AI in medicine for over 50 years. And this is a list of, some of the people that have done work in AI. I mean, you can see that the first journal of AI in medicine is 25 years old today, and so the history goes back a while ago. The first meeting in AI in medicine was close to 40 years ago. So the profession has been dabbling in this space for a long while, but our success rate was extremely low. And one could attribute that to a couple of things. One is lack of computational power, and two is insufficient data. So those are two critical inputs into artificial intelligence, and that's been the main reason why we've had no success, despite being in this space for about 50 years. Okay. What drove the emergence of AI in medicine as a discipline and as a field, and what's driving the kind of excitement is the convergence of these three things. One is computational power. Okay, the fact that computing power is increasing exponentially, and the unit cost of computational power is dropping. We're now in the zone of quantum computing. So computing power is increased. We have access to data, and we have access to storage, especially with cloud-based solutions. And then our ability to develop algorithms has actually improved as well. So the convergence of those four forces is kind of driving the resurgence and increased success of artificial intelligence. So, it's all of those things coming together. And that is only going to, improve exponentially. Computing power, access to data, methodology, storage, all of that's going to be on an exponential pathway, further driving the explosive growth of AI, not just in medicine, but across the board. Okay. In terms of why AI in medicine is important, and particularly in terms of being able to process data, what's important is our data sources in healthcare now in medicine are increasing pretty rapidly. With the advent of genomic data, phenomic data, environmental data, behavioral data, the data sources there are increasing tremendously, and processing power of humans remains static. And that's the big disconnect. We actually are in a situation of kind of cognitive, there's a cognitive gap. Our data processing capability as humans is pretty fixed. But data in medicine is increasing exponentially. As you can see in this graphic here, the sources of data are tremendous. There's no way, it's not humanly possible for a physician to use all of these data points, from these four broad buckets: genomics, phenomics, environmental, and behavioral, at the point of decision making. We just don't have that processing capability. So, AI has a critical role in augmenting our ability to process that data. So I think it's timely. And what we're going to see is the emergence of what we call deep medicine, this ability to practice medicine using all of these data points, which we cannot do currently. So we practice very, very superficial medicine at the moment. In terms of its application in healthcare, it's pretty broad. I've categorized it according to 4 different areas that AI could potentially be impactful. One at the population or public health level. This is absolutely critical that, in terms of disease surveillance and prediction, very important. I think this has been the shortcoming during the COVID pandemic, our inability to leverage data, to predict the onset and predict the spread, etc. So it's got a lot of value in population health, and I think it's going to lead to the emergence of a field that I'd like to describe as precision public health or precision population health. I mean, bear in mind, there is no such thing as the average patient. It's a myth that we have created in medicine. There is no such thing. And population health is based on the notion or the concept of an average patient. The average patient doesn't exist. So, our ability to be very precise, even at that level, is only going to be possible with AI. At the individual level, of course, this is where all the hype is around in terms of prevention, prediction, diagnosis, therapeutics, prognosis, all of those areas. And within that, there's certain disciplines that are, much more advanced than others, like the, radiology, pathology, dermatology space. So that's at the individual level. One of its biggest impact currently is on actually health systems in administration. And, the reason for this is it's not patient-facing. It doesn't have all of the regulatory and ethical and safety issues that we have to worry about. But it's very important, and this is a low-hanging fruit for AI. And my advice, to all health systems is this is where you should make your investment, because it's a low-hanging fruit with tremendous opportunity to improve efficiency and effectiveness. Bear in mind, admin costs account for about upward of 33% of total health expenditure. The leading causes of burnout amongst all provider groups is administration. And AI has the potential to dramatically alleviate that. The fourth bucket is pharma and medtech. AI is disrupting the pharma industry, and the current pharma companies are all moving away from that traditional drug discovery approach to leveraging AI-based methods. And AI is used now to identify targets, to develop molecules, and to identify patients for whom those drugs would work. So, it's driving the precision pharmacotherapeutic space as well. And, on the horizon, we will have precision therapeutics where drugs will be designed for individuals based on, those four components that I gave you: genomics, phenomics, environmental, and behavioral inputs. And then, of course, in the medtech and devices, especially in brain-computer interfacing, AI is going to play a critical role. There's already a lot of technology that, converging AI, robotics, brain-computer interfacing that's already being deployed in healthcare. Tetraplegic patients can now walk because of advances in AI, neurosciences, brain-computer interfacing, and robotics. The advances in those, but the convergence as well. So this is kind of the landscape of its different applications in healthcare. And, a lot of you on this call would be in that individual health space. And it's, not necessarily where the low-hanging fruit is in terms of application. Okay, in terms of the hope and promise, as I said, this is, everybody is excited about this, and this is why you probably listed this as a subject, as a topic to discuss, because there's a lot of, good work out there, and there's a lot of signs that this could be pretty disruptive. Okay, I've just used a couple of examples. There's a host of cases out there showing how AI can be disruptive, and most importantly, can actually allow us to practice deep medicine. That's its biggest value, is we can do what we're doing now, but do it far better. There's been a whole lot of work being done with, by Google, the Arvind Eye Hospital in India, and by Mayo, just by analyzing retinal scans. And you can see that by analyzing retinal scans, you can actually, identify patients at risk of various conditions, and actually diagnose conditions as well. I mean, you can tell gender, you could tell age, you could tell race, you could, diagnose liver disease, risk of cardiac, all from a retinal scan. And what you're seeing now is the emergence of commoditized retinal scanning equipment. So you can see the impact of that, that individuals, will go to a mall, have their pupils dilated, look into a piece of equipment, do the scan, and pretty much get a reasonably holistic risk profile based on that. In fact, there's already a company out there, it's called iCheck. So you can look that up, and that's what they do. This is another example of deep medicine, when you subject traditional ECGs to AI interpretation. There's a whole lot of stuff that you can predict. The AI is able to see things that we cannot see as humans. And this is really critical, that, we can also predict the risk of cardiac issues using ECGs, which an ECG should be for. It shouldn't just be there to, retroactively tell somebody they've had a myocardial infarction. So we're in the predictive space with EKGs. And as you can see, it can also detect multiple diseases as well. And ECGs are commoditized. You can buy a cardiac device for $50, and if you couple it with AI, you commoditize a lot of medicine. Really important for patients on dialysis because, you know, you can actually measure potassium levels using ECGs. So measure it accurately. And, you know, you will know that when patients with renal failure actually, have dangerously high levels of potassium. That just from ECG. So that's just another example. This is an example of X-rays, being able to diagnose cardiac valvular disease and diabetes just by looking at X-rays, And so it's pretty powerful. This is what I mean. It's deep medicine. And there are a lot of examples of this. A lot of articles published on how pathology, dermatology, radiology, is being positively impacted by AI solutions. A lot of the data out there seems to suggest that in these three specialties, AI is starting to outperform pathologists. So, that has implications for productivity and for quality as well. A lot of work there. This is one of the latest publications. It came out of Sweden that demonstrated AI as being more efficacious at reading mammograms than humans as well. So this was a pretty big study. And, so that's kind of the impact. What you will notice is most of the impact is in three areas. It's in radiology, it's in pathology, and it's in dermatology. That's because we don't have true artificial intelligence. What we have is, computer vision or image intelligence. The computers are really good now at image intelligence, and that's the reason why those three disciplines are furthest down the line. Okay. This is an example of, generative AI, large language models like ChatGPT, et cetera. You're probably familiar with this study that, they're starting to answer questions at an increasing rate of success on par with humans or even better as well. But it's not as simplistic as that. But, the point is that it's starting to happen now. Infectious diseases, I think, is going to be the biggest impact of AI. And recently, AlphaFold, a company, that does work on using AI to understand proteomics, won what's called the American Nobel Prize, the Lasker Foundation Prize. And generally, if you win the Lasker Foundation Prize, it's a pretty good predictor of you winning the Nobel Prize. So look out for these two guys. They're Google guys. AlphaFold came from there. A lot of work in proteomics, and by definition, that's going to transform the drug discovery space. Okay, I'm not going to go into each of into this slide in detail, but suffice to say, there are some really successful companies out there that only develop drugs using AI. Okay. They identify targets, they identify molecules and patients as well. And they're able to dramatically reduce the time it takes to discover. And it also helps for clinical trials as well that, we don't have to do it traditionally. Vaccine development, is becoming, is going to be one of the beneficiaries of these advances in proteomics. And that's just the diagnostic space is also going to be transformed dramatically. Some examples of that. Of artificial intelligence and robotics. I can tell you, the world's first fully autonomous dental surgery has been done 2 years ago in China. So, there was no dentist in sight. And the robotics only used imaging from the patient, and those dental implants were done more accurately than human dentists and taking 15 minutes each. So you can see the potential impact that the convergence of robotics and AI is starting to have. Okay, and I think you're going to see a lot of space there. This is the rehabilitation devices I was talking about. There are already several companies in the market, capitalizing on the convergence of robotics and AI in the rehab space, and that's going to be growing even more. there's a lot of work on the back end on what's called sentient intelligence. So imparting this ability of AI and machines to have emotion, and that is going to improve as our knowledge of the brain improves. Bear in mind, the brain is the least understood organ at the moment. But part of the brain initiative is to actually decode how the brain functions. And when we can reduce brain function to 1 and zeros, the code, then AI will develop sentient capacity. But at the moment, there's a lot of work being done in that space. So, it's very conceivable that you're going to have empathetic AI and empathetic robots on the market pretty soon, because there's a lot of work being done there. Of course, as I said, one of the key benefits is in driving the administration, and generative AI is already being used for this and having tremendous impact on the administrative burden of physicians. Some of the empirical work seems to suggest that already, that job satisfaction increases, the time it takes to perform specific tasks drops tremendously, and the overall confidence of using automation, especially in admin, increases. Right? So you can actually pull up this study. It's pretty exciting for the future. There's also some work now on productivity in terms of clinical productivity. By the way, it's interesting that over the last 2 decades, general productivity in the US has increased about 26-27%. Healthcare has been minus 13.5%. So we have a productivity problem in healthcare. And this is the first randomized trial that actually shows that, when you couple physicians with AI, that productivity actually goes up. So, it addresses one of the key issues in AI. Okay, so that's all the good stuff. It's all the hype. We're all getting excited, really good stuff. But there are lots of risks of AI that you have to be aware of. I'll tell you straight out, you'll never find a health system that's actually deploying AI as a patient-facing solution. It doesn't exist, okay? A lot of the work being done is research and experimental and clinical trials, etc., because of these issues, the risks. And, patient harm, already examples of that, misuse, bias, lack of transparency, privacy issues, amongst others. All of these are critical constraints that we need to resolve before AI becomes mainstream. There's just some examples. You may be aware of this. This was the EPIC sepsis AI model that, study found that it although it's used widely, but it predicts sepsis very poorly. This is the downside of AI. This is just one study. There's lots of studies there showing the potential for AI to worsen bias. So that's a major issue that we try to address in this study in terms of evaluating AI in clinical practice. This was a meta-analysis. And the findings are not surprising. There's some positive outcomes, what I just showed you, but there are a lot of defects in that. Most of these are single center homogeneous population-based studies, so you can't generalize it. If I develop a algorithm to detect nodules in lung x-rays amongst a Swedish population, that solution is not transferable to any other population. So these are the issues, and this is what these randomized studies and meta-analysis are starting to demonstrate. This is another issue. I've taken this one case. These are machine learning publications in dermatology with dermatologist involved. And as you can see, with time, the number of clinicians involved or included in these publications are dropping. So that's a big issue, as far as AI, the development of AI solutions in medicine is concerned. It does not have the clinical representation that it should. This is another example of how AI can confuse surgical skin markings with skin conditions, so the efficacy issues, there are a lot of these issues that we need to work through. This study, the applicability and generalizability of AI algorithms rely on high quality training and testing of data sets. The sparsity of data set descriptions, lack of data set model transparency, inconsistency in disease labels, and lack of reporting on patient diversity presents concerns for the clinical translation of these algorithms. Now, this is a JAMA Dermatology article. These are the problems we face at the moment, and this is why, at the moment, it's hype and hope. And, until we address these, it's going to be difficult. This was just published. I actually just came across this article this morning, and where they've looked at multimodal generative AI. So ChatGPT that could use imaging, voice, natural language, etc. And, the observation is pretty stark, and shows that GPT-4, that's the new multimodal, demonstrates proficiency in distinguishing between medical image modalities and anatomy. It faces significant challenges in disease diagnosis and generating comprehensive reports. So, a big study. How am I doing for time? I think, have I overshot the time? Yeah, it looks like I have significantly. Can I stop there? These are major issues that we need to look at: regulation, ethics, adoption, and the legal aspects bundled together. We refer to this as responsible AI. And this is, to me, the biggest space that's going to drive and determine the future of the success of AI in medicine. It's definitely an area that I have an interest in as well. And it includes these 4 areas. So I'll stop there. I know it's, and take any questions or wait for the discussion.
Thank you, Dr. Rubin. That was an amazing journey into the world of AI, where we're all headed.
Yeah.
So I think we'll keep the questions for the panel discussion
Okay.
time. So we have 2 more speakers who are both physicians, but at the same time practitioners in artificial intelligence, if that's even a term. Dr. Johnson Thomas is the section chair of endocrinology at Mercy Springfield in Missouri. He's also an associate faculty at Missouri State University, where he collaborates with the biology department to create novel therapeutic agents. In addition to general endocrinology, he has a focus on thyroid nodules and thyroid cancer. He has published in multiple peer-reviewed journals, presented at several national meetings. He's a recipient of the Kenneth Simsick Award for Academic Excellence in Endocrinology and a Researcher of the Year from Mercy. His research focuses on molecular markers, radioactive iodine-resistant thyroid cancer, minimally invasive treatment for thyroid nodules, and the use of artificial intelligence in thyroidology. So he's going to tell us about his work, and especially a software that he has created for using AI in medicine. Dr. Thomas.
Thank you for that great introduction, and thank you for inviting me to this AKMG panel discussion. We are living in an exciting time. So many moons ago, when I married my wife, who happened to be a software engineer, she used to work on EEGs. So I said, well, wouldn't it be great if we could read our minds or thoughts using EEG? And about a month ago, it happened. You could actually predict what a person is seeing just by reading the EEG. Well, it's an oversimplification, but things are moving so fast. So I'm very excited in AI, and I have been coding from my school days. So when I finished my fellowship, thought about using that skill in the problems that I'm facing in endocrinology. So these are my disclosures. I'm a CEO of AIBX. I have 2 patents in thyroid-related artificial intelligence. So in my clinical practice, I see a lot of thyroid nodules. And in fact, 1 out of 2 women over the age of 50 may have thyroid nodules. Most of them, they are benign. But we end up doing millions of biopsies worldwide to find this small amount of cancer. Even when we find these thyroid cancers, it usually does not increase morbidity or mortality. And in many centers, they are using active surveillance, that is like not doing surgery, and monitoring small thyroid cancers. So we thought about using AI to address this challenge. Can we use AI to predict thyroid cancer from thyroid ultrasound images? In a typical AI, what we get is you give an image to the AI, in this case, a thyroid ultrasound image, and the AI software or the model will say this is benign or this is, cancerous. So being a practicing physician, how do I trust the output of this AI thing? Right now I do a biopsy, a pathologist looks at it and give me a reading. So we wanted to emulate what a radiologist or an endocrinologist does, how the process in their mind when they see an ultrasound image. So after doing a lot of these biopsies and seeing the results, you have a mental model of how a malignant nodule looks like and how a benign nodule looks like. And when we see a new image, we are able to access this memory, and I'm like, oh yeah, that looks like a malignant nodule, I should biopsy it. So we tried to emulate this in our AI model. So rather than giving you a direct diagnosis, whether this is benign or malignant, which it does, then it will also give you like X number of similar images, let's say 3 similar ultrasound images with known diagnosis, either through biopsy or by histology. So even a non-experienced clinician, we are really good at matching images and comparing images. The AI will give you 3 images with diagnosis, and then you can look at your image and see whether your AI is predicting based on that knowledge base, and you can either reject or accept the AI diagnosis. It also gives you TIRAD scoring, like description of the TIRAD score and the final score and a recommendation. So by using this explainable and verifiable methods, we kind of make it easy for the physician to make a final decision, quote unquote, at the point of care. And that's how, that's kind of the work that I'm doing right now. And to explain it, so if you give an ultrasound image, as you can see, the test image on the left-hand side, the AI program brings up 3 similar images with known diagnosis, and then it, gives you a sentence like, well, this nodule resembles a benign nodule based on our database. And how does it work? Hopefully this plays, and maybe we can see.
Hit submit.
So you upload an image.
You can see the diagnosis below the area of interest. We can now browse through similar images and diagnosis. Below that, you can see TIRAD's description and recommendation for biopsy. Finally, you can see the PDF report here. This can be incorporated into EMR. Let's hear what the experts are saying. Dr. Orloff, professor at Stanford, noted how unique AIBX is. AIBX has conducted national and international external validation studies.
By the way, the lady who was talking was completely generated by AI. So, this is one of the aspects that we are working on. This is not FDA approved. Like Rubin was saying, we do not want to take this without external validation studies. So far, we have conducted 4 external validation studies. We are doing more to make sure that the accuracy, oh, that's not a good term, but yeah, the model performs as we want it to. So we are continuing to do more research and getting more external validation study, because as a physician, it's important to me that if we create something like this, this is clinically usable and validated in multi-center trials. So that's one thing I'm working on. So most of us are familiar with using UpToDate or a tool similar to that when we are faced with a clinical question. But what if you could ask a question like you ask Siri or Alexa and get relevant answers from the medical text? So that's something that I've been working on. And this is a very small demo. It's not perfect, but I just wanted to show you how this works. How do you treat hypothyroidism?
Levothyroxine. The optimal daily dose is 1.5 to 1.8 mg per kg of body weight. ESH measurement should be repeated after 4 to 12 weeks and then every 6 months, with adjustments made according to laboratory findings. In some cases, levothyroxine, lidocaine combination therapy is used.
Treat radioactive and refractory thyroid cancer. Please explain in detail.
Is typically treated with systemic therapies. These therapies may include chemotherapy, targeted therapies, or a combination of both. Chemotherapies used to treat RNAi include doxorubicin, paclitaxel, and cyclophosphamide. Targeted therapies used to treat RNAi include tyrosine kinase inhibitors, such as lenvatinib, monoclonal antibodies, such as nivolumab, and immunotherapy, such as interleukin-2. In some cases, radiation therapy may also be used.
So, I mean, I don't agree with all those answers, but you can imagine if you feed the AI with, let's say, an endocrine text, you can get answers from that text using retrieval augmented generation. So that's something that I'm working on just for fun. The other thing you could all access is a search engine called medisearch.io. Here I'm asking, how do I make a diagnosis of celiac disease? And you can see it gives you a pretty good answer. Large language models can hallucinate, meaning they can just give you sentences that are smart but may not be accurate. So in this model, you could actually get the answer along with the actual reference for that medical journal. So if you click on that, it'll take you to that journal article, and these are not hallucinations. So you'll actually find those articles on the web, and you can read and verify that the answer is correct. Once you ask a question, the AI will automatically generate few follow-up questions. As you can see on the lower side, one of the questions it generated is, what are the characteristic histological changes that are seen in celiac disease? You could click on that to get answer. Or, why is it important for individuals to continue consuming gluten-containing food prior to testing for celiac disease? So in the future, we may not be using, reading a whole bunch of text in UpToDate, and maybe even UpToDate might itself change, but we might be getting these specific answers at point of care, so we are able to take care of our patients in a rapid, efficient manner. So I don't think anyone likes prior authorization. So most of you might be using this tool. This is called DocsGPT from Doximity. Usually when you have to generate a response to prior authorization, you have to look at the chart, look at some literature, and write up a good letter and fax it or mail it to your insurance company. So here I'm asking DocsGPT to write a letter to Aetna supporting the medical necessity and clinical appropriateness for Humira in my patient. I mean, you can make it even bigger, like give more clinical details. This is a HIPAA compliant website. So as you can see, it automatically pulled up my address, date, and Aetna's address. And it wrote a beautiful letter. Maybe one of the rheumatologists can't say whether it's accurate or not, but I had tried it for endocrine stuff, and it works pretty good. And once you generate it, in the future, you will be able to pick one of these insurance carriers and then hit the fax button, or your medical assistant can actually use this, create an initial draft, and you edit it and send it. So this typically reduces the time to create a response from 5 to 10 minutes to a few seconds or minutes, so saving time. We are also, our system, health system, has also collaborated with Nuance and Microsoft to introduce generative AI, and our primary care physicians will be getting the AI scribe, and the second phase is where the AI scribed note will also be edited by a real physician, and by the time you're done seeing your patient and maybe 5 minutes later, you'll have a full note with, you know, whatever you discussed, and you might have to make small edits. So hopefully that will bring the joy of medicine back, so that you're not typing in front of the patient, you're actually talking to the patient, and all the documentation that you have to do is done there. There are also exciting work where when you order, let's say, CT scan, the computer will, or the AI system will automatically look for things the prior authorization insurance is looking for and incorporate that in the note, and making our life easier. Hopefully these hopes will come to fruition, and we will have more joy in medicine in the future. And I'm going to stop my presentation. Hopefully we'll be able to answer some of the questions at the panel. Again, thanking AKMG for inviting me.
Thank you, Dr. Johnson. That was a great application of AI, and amazingly that you have coded it yourself, being a physician. So on the same lines, the next speaker has also, he has already in his career so far as a physician, he has already done 3 careers. So he is a neurologist. Dr. Gireesh is a neurologist at Advent Health, Orlando. He finished his MBBS from Calicut Medical College. He did a master's in medical technology from IIT Kharagpur. And then he took a PhD in computer engineering on artificial intelligence from the University of Central Florida. And his residency is from New York University and Johns Hopkins. He is board certified in neurology, epilepsy, neurophysiology, and neurocritical care. And it's our pleasure to have Dr. Gireesh talk to us about his work.
Thank you. Thanks, Raju, and AKMG team and CME team for having me. Great to talk about my work here. As Raju was mentioning, I come from the side of brain science to the AI because I was doing a lot of work, some of the works in the brain plasticity and all, and then I got interested in how the neural networks work, and that's where I had more exposure to the side of the AI. So my work is related to the potential application of AI in neurology epilepsy. In Rubin's words, it is more like a narrow AI, like a specific application to target something. And then I go into how AI can expand the boundaries of medical knowledge itself by looking into how the AI is actually learning. That is a secondary interest of mine. So looking at the, I'm an epileptologist, so treating patients who have very refractory epilepsy, it is very challenging. And at least 30% of these patients have difficulty controlling their seizures. You give multiple medicines and still it will not get controlled. And these patients will undergo surgery. And before undergoing surgery, they have to go through a multimodality evaluation, which will include like EEG, MRI, PET scan, and all. And then we will usually, as a gold standard for evaluation of epilepsy prior to epilepsy surgery, we do the intracranial electroencephalography, which is a branch which not only is limited to epilepsy surgery, but has been used in Parkinson's disease and in other disorders, and also from the neuroprosthetic side also, where we can analyze the intracranial EEG and find what exactly the brain is doing. The main target for us is to make sure that we are resecting or doing the surgery on the right location, exactly in that location, and not any more than what you need to take out. Like brain is precious. So if you don't want to touch any areas of your strength, motor area and all, so from that standpoint, you need to have this intracranial EEG. So initially it used to be a limited amount of data, but now this data is huge. You are recording from so many locations, and then we run into the issue that Rubin was again mentioning, the huge amount of data. So usually these records run for several days, and patients are in ICU, and the data will be coming from maybe 200 channels. So that's where I thought it is hard to decipher this data. Maybe we can use AI as a tool to evaluate this data. So this is I will not go too much into the detail, but basically I was using a neural network model. Like we employed both a convolutional neural network and a deep dense neural network method to analyze where the signal, where the epileptic regions are. And I will jump into the result directly from here. So this is an example of the data that is coming out. And the data will go on for maybe like 5 days, 6 days, 7 days. In this case, I'm looking only at 1 minute of data, okay? And my goal is to predict, can I tell where the seizure is coming from based on this data, versus the clinical conclusion, which usually comes after multiple days of recording of the data, and our the epilepsy board meets and comes into conclusion where the EEG, where the epilepsy is coming from. So this is a comparison. This is the AI model predicting that this is the area where the seizure is coming from. And this is the conclusion after multiple days of recording. And this is where the patient had the surgery and the patient was seizure free. So this is a comparison. This is 1 minute of data versus several days of recording. So that points to the huge potential that the AI can have in terms of minimizing the duration of the ICU stay. And it's not only that, this patient is sitting with multiple electrodes actually in the ICU, and if he has a seizure, it is sometimes difficult to control all those situations. So you're talking about how we can use AI as a very effective tool to minimize those prolonged ICU stays, like medical complications and all. And these are the additional, the same methodology applied with multiple patients. And you see that there is a good correlation or like relationship between where the AI predicted the seizure could be coming from based on that limited 1 minute of data versus the multiple days of data. So it's hugely, it has a huge potential. I'm not telling it's completely foolproof. We are trying to do validation studies with other centers so that we can try to employ it as a standard medical method. Another interest of mine was to look at what the AI is doing, going back to my brain science interest. Like this is the idea coming from image analysis. They call it heat mapping. What particular features are AI using to predict maybe this image as a cat versus this image as a dog? So what is the advantage of that? Now I can ask the same question about my brain signal and try to answer what is it looking for when it's telling this is the epileptic zone. As a neurologist, we already know a little bit about where the signals are going wrong, where the signals are, what kind of abnormalities are happening. But my question was, can the AI help in expanding that boundaries of information? So I will not go too much into the details. Essentially, the AI points to those areas of high energy regions, which is much, the correlation between that high energy region and AI's predictions are much more robust compared to that correlation between our raw signal analysis. So like, in a sense, the AI is actually able to focus into that high energy regions much better than what we would have done just by looking at the with our vision. So that probably points to how AI is able to reach that prediction much effectively. And on the other side, it also points to the fact that these high energy regions should be are playing a vital role in the epileptogenesis, which is a little bit of a step beyond what we know about the the abnormality of the epilepsy itself. So that is one of my interests, and that seems to be a very useful area of application of AI. So in summary, I would say on one side, AI tools can effectively improve the medical care. With as of now, they are narrow AI, like just like other applications, like in the field of retina or mammogram. In this case, it is for predicting the epileptogenic zone. But on the other hand, the other interesting aspect is the AI can actually enhance our existing medical knowledge by pushing the boundaries of our understandings, because AI may be in several ways, maybe understanding the signals, the brain signals, much better than what we can appreciate with our just visual examination and all. Again, thank you for having me, Raju and team, and the entire AKMG, and thanks for listening to me. Thank you. And I'll be happy to take any questions.
Thank you, Dr. Gireesh, for that beautiful application of AI for epilepsy. So now the next part of this program, we will open the chat for questions from the audience. Please type your questions in the chat box. And also, just a reminder for everybody, to get CME credit, please input your emails. That's where the links to the CME credit will be sent. You can put that in chat. For the panel discussion, we have 3 moderators who would be asking the questions for you. So Dr. Khalil Ashraf is the Director of Clinical Research at the Hematology and Oncology Associates of Alabama. He is also the Principal Investigator for Central Alabama Research and a consultant hematologist oncologist. Dr. Shija Pularkar is Professor of Pathology at the David Geffen School of Medicine at UCLA. She's also the Program Director of the Hematopathology Fellowship Program. Dr. Ravi Raghavan is a Professor of Neuropathology at Loma Linda University Medical Center and at the University of California, Riverside. So we have now questions for the panelists from the moderators, and please also type your questions in the chat. Your chat questions will be seen by the moderators, so please go ahead and type your questions in chat. And also, Gregory, if you could open the chat to all, that would be nice.
Okay.
Okay. All right. So I'll hand it over to the moderators now.
Good afternoon, everyone, and welcome to the speakers once again. Wonderful talk. You have opened up an entirely new area of discussion here, and I can see about 70 people have joined us. It's great. I have a question to start out. The question I have is, how can an average physician out there prepare himself or herself for the AI era, what are the opportunities they have to educate themselves and prepare for it? And that question goes to all three of you. I mean, maybe Johnson, Rubin can start the discussion.
I can take that. I mean, really important question, because I think it's one of the key constraints to adoption is literacy. And we are acutely aware of the importance of improving AI literacy, not just amongst physicians, but pretty much the whole healthcare workforce. Now, there's several initiatives ongoing. Firstly, there are a lot of these open source MOOCs that are available. You could easily find them. I think there's a organization in California that's called MI10. I think it comes out of CHOC. They have a host of AI literacy programming. We have at the University of Alabama at Birmingham, we're the only school of medicine that has robust academic programming in AI in medicine. So we have a graduate certificate. That's a pretty good entry-level program for physicians. It's 5 modules. You can get it done in a year, and you actually have a graduate certificate in AI in medicine from the School of Medicine. And we are rolling out soon a master's in AI in medicine. That would be available, obviously, for the guys who are more want to get more technical, and a PhD as well. So I think you're finding a lot of programming becoming available. But it takes a long time for academia to get these programs approved and rolled out. I think physicians, need to take the responsibility to develop that literacy on their own in the interim. And there are a lot of there's a lot of programming out there that's available at the moment. That's my advice.
What about Johnson and Gireesh? Do you have any comments?
Yeah, I would say agree with the same thing. There's a lot of courses available. I have seen at least a few self-taught physicians who can now code and create AI models. And the other thing is, it's cool to generate these models and stuff, but we also need to understand how these models are evaluated, because in the future, in the near future, you might be approached by a company saying that, hey, we have this great AI which can diagnose X, Y, and Z, and they might show you some metrics which looks good. So it is really, we should learn how to evaluate these things. It is very different from drug testing, and having good knowledge about these things will be important, because you as a section chair or a physician working in a department might be asked about a vendor. Hey, should we buy this? They said they're giving a good deal here. So understanding that part of like how good that AI model is also important. So for people who ask me, how do I get started? One of good courses that is available for everyone online, so you don't have to, go to a university or anything. AI for Medicine Specialization from deeplearning.ai. It's Coursera. It's available for everyone. It's a really decent one, and they also have a specific course for large language models. But if any of you have specific interest, I'll be happy to direct you to those specialized courses. Happy to respond via email or Twitter or whichever medium you prefer.
Thank you. Gireesh, anything you wanted to add?
The only thing I would say that I think that when I see medical students now, they seems to have more interest. I mean, the students do have a lot of interest in this field. So that's quite promising. And I would say that, yeah, we do need to know what the AI is doing. That not only is helpful for us, but from a patient acceptance standpoint also, because like if you are using a tool which you don't know anything about, the patients may not be interested in using it also. Yeah.
Thank you. In the interest of time, I'll hand over to my colleague here, Khalil Ashraf. He may have another question to ask.
Yeah, thank you so much. Amazing talk by all three of you, and learned a lot. And we have several questions in the chat box also. So I will just quick question. This is kind of practical in terms of insurance and reimbursement issues. When you use AI for, how does that?
Yeah.
Have you all have any experience with that? At the end of the day, that makes a big difference in US.
Yeah, absolutely. I mean, it's one of those, the last slide I had up, said that these are the 4 areas that we really are going to be critical to the success. And one of them is the legal aspect of it. Khalil, because AI is, I mean, frankly, AI is not used in clinical practice and clinical care at the moment. There's a lot of background work going on in terms of to understand who's liable, whether it's the developer that's liable, whether it's the physician using it, and then would the physician be liable if they don't use AI? So these are, these are all issues that we do not have answers to at the moment, and it's a very important, it's something very important to consider. But I think in the interim, what's going to happen that the patients are going to have to give consent to the use of AI. So this whole notion of transparency, not just in the AI solution, but in its use, is going to be important.
Any comments, Johnson?
So right now there is very less reimbursement. For example, there are some CPT codes for thyroid AI, but they are category 3, so you don't get reimbursed. But think about using PACS. Do you get reimbursed for using PACS? You don't. It becomes cost of doing business, right? So if you're able to reduce the read time, and if you're increasing productivity that way, then your system might say, well, this is worth investing in. And the other thing is we are already in many subspecialties, we are already using AI without even realizing that it is AI. For example, we've been using insulin pumps, we now artificial pancreas. So it's been used for, I don't know, maybe 5 years now. So it's AI, and that technology is getting better and better. And right now we have a pump which can kind of keep the blood sugars around 110, 140 range. So and we are using it. I'm using it. It's off the shelf. I can prescribe it to a patient. They will get it. So who pays for that? Insurance pays for that, right? And we are using AI in our hospital too. So, I mean, just like Rubin was saying, when I went to my last eye exam, my ophthalmologist asked, hey, you want to get your retina looked up by AI? It's $35. So I, as a patient, had to pay that $35. So yeah, there are different methods of getting reimbursed, but it's very challenging right now. And when that barrier gets crossed, there might be a floodgate of people trying to get in, because right now there is not much reimbursement.
Gireesh, any quick comments?
Yeah, I think the idea will be the same. Like even in the EEG world, there is an idea of quantitative EEG which can be reimbursed. I think it will slowly build up on that kind of idea in the future, I hope. Yeah.
Let me, Shrija, there are some excellent questions from the comment box. I see some from Shelby, who is actually an AI expert himself. So
yeah, I can take one of the questions from the chat box. So it looks like there is a question about how AI adoption in a pure primary care setting. What does it look like in a pure primary care setting?
Well, I mean, I think, there's some really good use cases of AI being used in the primary care setting. A lot of those are chatbot based. In fact, one of the best use cases is a British company called Babylon that launched their chatbot in Rwanda, and made primary care services available to 2 million people just with a flip of a switch. So and that initiative was called Babil, and it's a really good example of how you could use chatbots to pretty much provide GP level care. I think, you know, there are a lot of these solutions available in the US as well. You know, UAB has one that's powered by a company called Zipnosis. You know, so I think it's pretty impactful. The issue is adoption. These solutions are out there, you know, but I don't think there's a level of trust built yet for patients to embrace this as their first entry into the healthcare system. So that's the issue. But there are a lot of chatbot-based primary care solutions that are out there.
Great, thanks. How about Johnson and Gireesh? Do you have anything more to add?
I think the initial application will be more in the administrative section, as Rubin was alluding in the past. So if you go to our, Mercy's website, you're greeted with a chatbot. Say, I want to set up my appointment with Dr. Thomas. They will do that for you. Have specific question, it gets directed to our Epic team. The next thing is we are rolling out this generative AI for our primary care physicians initially to make the documentation easy. That's what I was talking about before. You see the patient, and then you have the report. I mean, your whole H&P or your SOAP note there. And then the other thing is getting prior authorization, not the one that I showed, but integrated with your health system. So all the stuff that you need for prior authorization, it's happening in the background. As soon as you hit the button to prescribe something, that information is populated, and then they can take care of it in a much speedier fashion. So this is where we are at in our institution, but there are a lot of other examples where you can even provide care. But again, like Rubin was saying, who's going to trust that? We haven't reached that level of trust yet.
Yeah. Any more questions? I don't know if there are any more questions from the audience.
I thought Shelby had a question. Ashraf said.
Yeah, Shelby, he's an AI expert himself. He's from Johns Hopkins. Maybe Shelby, you can unmute yourself and talk.
Hi, thanks, Ashraf. Sorry, I'm outside, so that's why my camera is off. First of all, thanks to all the three speakers for enlightening talks, updating us on various aspects of AI and how it might be used for diagnostics and precision medicine. The question is about the data, because all three of you talked about some of the data hungriness and failure of translation and adoption and all those things. And I just wanted to pose a question. In your experience working with institutions, health systems and institutions are fiercely protective of their data, and it's very hard to share data between our institutions. And in your experience, can you give us some of the ways in which we can navigate the regulatory issues of data sharing, and how have you managed that, or how are you planning to manage that, and any tips for us to enhance our data, because then the improvement in translation and adoption is going to occur?
Yeah, there's a very short answer to that. It's almost impossible to share data, okay? And it's not a battle worth going into, because it's never going to happen. So you know, that's an aspirational goal. But so the question should be, how do we get around the challenge of sharing data? And there's a lot of work being done in what's called federated learning, so that, you know, we are not sharing data. What we're sharing is insights from the data. And, you know, so that's one approach to mitigate that, because you have, you know, the ideal AI solution is going to have to leverage data globally, not just from one institution or one state or one country. And the only way we're going to do that is through what's called federated learning. So, you know, essentially what happens is, theoretically, each one of our organizations uses their own data, develops their own insights, and then we pool the insights to better improve the insight. So, that's a simplistic explanation of what federated learning is, but that's the way that I think the future is going to be around. Not sharing data, but sharing insights.
I mean, when we started collecting data for our studies back in 2017, it was very easy. People were not thinking about data privacy and stuff like that. But our IRB specifically said, hey, you cannot collect any identifiable data. But there is also a caveat there. For example, there was a study of CT scans of the skull or brain, let's say, and there was no data about the patient. But then researchers were able to reconstruct the patient's face from the anonymized data. So that's the trouble we are having. So like Rubin was saying, yes, federated learning is there. When I collaborate with so to do federated learning, the institution that you're collaborating with should also have expertise in that, right? So if you're collaborating with people who doesn't have that becomes hard. So another way to get away with that is to maybe share your model, but may not the last layer, or you could get embeddings. Like that's how ChatGPT and things work. So if you don't want to share your model, you can share a part of the model and you will get embeddings out of it. And you as a scientist or researcher, how to process that embeddings. So the researcher who are collaborating with you on the other side, they never send you the image, they never send you the data. You're actually getting numbers, which doesn't mean anything to anyone unless you know how to analyze that. And you cannot really go back and reconstruct that data. So that's another way to do this. Yes, so there are different ways, and there are different countries where the regulations are less and it's easy to collect data. But when you're working with this, you want to be truthful, you want to be accountable, you want to protect the patient's privacy. So and there are a lot of publicly available data, believe it or not. If AKMG students are interested, you could do research on that. Breast cancer, CT scans, x-rays, tons of publicly available data if you want to learn and study. But then you need external validation study where this sharing this things needs to be standardized.
Okay, I have to say I'm learning a lot today. Thank you to the three of you, but I also see a lot of questions in the chat box. So first of all, I have to say thank you to Dr. Urmila Kovilam, who has made an excellent suggestion, and that is that due to AI, it has increased the sensitivity of pap smears by 5 to 6%, which is excellent. And there is a question, what do you think about the job security of the PCP or hospitalist in the era of AI?
Yeah, I guess that's always the question you're going to get when you're addressing physicians, but I guess the commonest response is always that PCPs or physicians who don't use AI will be replaced by those who do. That's the simplest answer. I think it's not negotiable. I think physicians have to become literate about AI and figure out how to augment their practice with AI. I think that's absolutely critical. As I said, down the line, it's conceivable that you'll be held liable if you do not use AI. So, there's two sides to the coin. So that's my short answer. I don't think that's imminent in the next few years, but I think it's just going to become the way we practice medicine. It's going to be the norm.
Got it. Anybody else has any comments to add?
I was recently listening to Jensen, who's the CEO of NVIDIA, which powers all these GPUs, and his answer to that was a similar thing, like what's going to happen to the job market. If you look at technology, our productivity has increased as the years passed. So I'm hopeful that AI will be able to increase our productivity. And studies have shown that when a company's productivity goes up, and if it's a good company, you actually hire more people. But as an individual, I might lose my job, but ultimately you're creating more jobs. And we might be enhanced by AI. And instead of saying, let's say 16 patients a day, just like adding a scribe, if I have a scribe writing all the stuff, I might be able to see 2 more patients. And if that's an AI, I might be able to increase my RVU. So yes, we need to use AI, but also know the nuances so we can be ahead of it and make corrections if needed.
Thank you for all who asked these wonderful questions, very relevant questions to the future of practice. We have time for one more question.
I have a question, if you don't mind.
Go ahead.
Hey, this is Samir Badaruddin from University of Kentucky. So in this era where a lot more of these models and private companies are coming up, how does a regular average physician distinguish between a lot of scams are going on? A lot of companies come up with promises that are eventually unmet. Even the example that Dr. Rubin Pillay mentioned, the Babylon, I believe, that was having a lot of problems in UK where they were over promising. And so that's something that I think we need to consider, more of a comment as well as question as to how to distinguish what kind of questions as a responsible physician should ask when companies are going to come through directly to you or through your universities or academic institutions.
Right. Yeah, I think there's a lot of work being done. A really good question. There's a sub area of responsible AI that's called responsible procurement. Okay. In fact, I'm working on a book right now on a guide to responsible AI that has a full chapter on responsible procurement. So it will actually give you guidelines in terms of how to vet and to procure. The reality is, I mean, every organization is going to have has to have some kind of governance structure to oversee, development, acquisition, deployment, monitoring of AI. And part of that governance structure is going to include people who are able to validate them clinically, validate them from a business point of view, validate them from an ethical point of view, and validate them from a social justice point of view. So, it's going to require restructuring if we're going to succeed at this, because of all of the challenges that AI in clinical medicine could potentially result in. So that's the short answer, but it's a really good question, and there are kind of frameworks that we're putting together to help guide that.
I think we do have some more very interesting questions, and I think we should definitely honor that. Ashraf, I see a question.
Dr. Elakkat had a question. It's AI's role specifically in anesthesia. I don't know, any of you can comment on that?
Yeah, there's a lot of work being done because anesthesia is data heavy. So it could be used on the operations side, the managerial side, using computer vision to observe how anesthetists work. That's becoming an emergent, and optimizing OR operations. That's very big. I think there's actually a lot of startup companies working with data from the anesthetic devices, etc. And a lot of that revolves around, predicting patients' response to anesthetics and that kind of space. But it's a pretty robust discipline, and the outcome of that is essentially you're going to be able to centralize the practice of anesthetics. You'll be able to scale it much quicker because of being able to monitor far more patients more accurately because you can predict their responses, etc.
Dr. Salim Shafiq is a renowned hematologist from UK. Shafiq, do you mind asking the question or your comments? Unmute yourself.
Yeah, I think it is very, very interesting. I think it's almost like, so much interest in AI now, because everybody, if you're not doing it, our planning team's already doing it for a complex radiotherapy planning, which saves, I was told, I'm not a radiation oncologist, but saying 4 or 5 hours of planning, which is such a complicated, and it's such a beautiful thing. And they're like, you can do more treatment. So it's more of not taking as a threat to your job, but your throughput can improve so much. And that's one thing. Other thing we just done is a lung nodule screening. It's a mass lung nodule radiodiagnostic. And that's also picking up so many, the human eye can miss it.
Yeah.
Sort of governance issues and all sort of things. Other one is for our morphology. Because I was telling at a hematologist, we see a lot of malaria parasites. So in screening a big field for a human eye, there is a limitation. So if they can pick up things, very low parasitization, and that sort of things, it's like a sky is a limit, isn't it? I think you should take it as a bonus rather than as a threat. That's what I think.
Yeah, really good comment, Salim. I think, I think it's, the key is, as I said, one of healthcare's biggest problem is poor productivity. And we now have, for the very first time, a solution that's going to help us really improve productivity. So, and then one of the other big issues we have is patient safety and quality. It's difficult to admit, but we have major issues on the patient safety front in terms of misdiagnosis and medication errors, et cetera, et cetera. We can now start delivering much better and safer care to patients as well by intelligence augmentation.
Yeah, I also take this one more question. What is the ethical dilemma that you have faced during implementation? I guess probably to Drs. Johnson and Gireesh.
Maybe I can take that. I'll say my perspective. Ethically, I was wondering how this is going to change the landscape, right? So my bottom line is what is best for the patient, right? Ultimately, what works best for the patient. So directly, directly looking at the current work, I don't have an ethical dilemma because I'm just doing the best for the patient. But I'm anticipating issues in terms of, like if I'm applying this model to another population, it is not going to work. So there will be huge issues in terms of the applicability of the same model in different areas. The problem with the AI tools is that unlike the individual doctor sitting in one location who is interpreting the data, the AI is going to interpret data throughout the world now, like depending on whether one product is successful or not. So that will have an impact in the way it is interpreting and coming into conclusions, different patients' outcomes. So that will be a concern for me.
So on that note, I would like to thank the speakers for their excellent talks and their wonderful thoughts about the questions, and for the audience being so involved. I know it's a Saturday afternoon and it's been a long session. Thank you all for participating and hanging on till the end. We have several more comments and questions. Dr. Vimoj Nair said radiation oncologists are using AI-based targeting in Canada. So we will compile all those questions and send it to the speakers, and maybe they can directly respond to you. Thank you all for attending. We'll keep the chat open for a little bit more. Please type in your emails, and the CME credit instructions will be sent to your emails. Mark your calendars for the next CME meeting in January 2024, and have a wonderful weekend.